So Dr. Manya said OpenMRS is going to be a game changer. And as you all know, last year we were in Nigeria, right? For the OpenMRS conference. So in honor of the Nigeria team, OpenMRS is the emperor, the conqueror, the champion, the lion is? OpenMRS is the game changer, right? My name is Pascal Mwele, as introduced. I am the Director for Innovation and Change Management at the Palladium Group, and I'm also the Technical Director for a project called DataFi. So it is my distinct honor and pleasure to invite the panelists, starting with Dr. Ganda, who's the, he's gonna introduce himself. Dr. Ganda, welcome. Let's appreciate him as he comes up. And then that will be followed by the representative of MOH Namibia, that is Mr. Kamati. Please welcome Mr. Kamati as he comes up. Welcome. And we have the only lady in the panel. Let me hear a round of applause as we all welcome the representative from Malawi, MOH, Dr. Alinafe. Mona Lisa, yeah? And then from CDC Kenya, representing the USG team, is Dr. Kimanga. Please welcome to the podium, to the stage. Last and definitely not least, from Uganda, let's welcome Mr. Paul Mbaka, representing MOH Uganda. So, OpenMRS is the game changer, right? Do you know the words? OpenMRS is a game changer. So, borrowing from Nigeria, we are saying the emperor, the conqueror, the lion is here. OpenMRS 2024 is here. So I'll ask Evans if you could queue up the slides. So we will have just one slide presentation by Dr. Ganda. We'll have them introduce themselves first, and then Dr. Ganda will start us off with his presentation. Karibu. Introduction, please.
Good afternoon. I am Dr. Gregory Ganda. I'm the County Minister for Health in Kisumu County. I'm also a member of the Digital Health Agency, a board member of the Digital Agency in Kenya. Thank you.
Thank you, Doc.
Good afternoon. My name is Meduletu Kamati. I am a developer from the country of Namibia at the Ministry of Health. I am responsible for the development and management of our systems. Thank you.
Good afternoon. My name is Dr. Inafembewe. I'm a medical doctor and I'm in charge of the Digital Health Division in the Ministry of Health, Malawi. This is not my first time in Kenya. It has become my second home. I think when I just joined Digital Health, the big thing that happened is that we hosted this in Malawi. So yeah, it was a bit overwhelming. I didn't know what I was getting myself into. But I met great people. So I met Paul Beyondich, who has been a good resource teaching me what this is all about. I met Stephen Wanye, who is now like my big brother, who I can, and I know Dr. Ayub Banya. I just think he's funny. You heard him, right? Every time I sit with him, I laugh. So I'm very happy to be here and honored to be the only lady in this panel. Thank you.
Good afternoon. I'm honored to be sitting next to the only lady. My name is Dr. Davis Kimanga. I work for CDC in Kenya. My position is Deputy Associate Director for AP and Strategic Information. And I've been lucky enough to have been part of this journey from way back in 2010. So very excited to host the third OpenMRS conference in Kenya. And we are very excited to show you the great work that we have managed to do this far and help you not to reinvent the wheel. Thank you. And karibuni.
Good afternoon. My name is Paul Mbaka. I work at the Ministry of Health in Uganda. I head the division that is responsible for health information as well as digital health. I mean, everyone has tried to associate with Kenya. I hope I don't cause myself problems by overexposing myself. But I'm a Kenyan by marriage. My wife is... You know, there are those people from the coast who, when they sit on a chapati and give it to you, you can never recover. So I am a victim. They say that what? Walinikalia chapati.
Yes.
Yeah, that one.
Thank you very much. Mr. Paul. So Paul came to Kenya and left with someone. So a week is a long time, eh? So you could live with someone. Ponyoka na mtu, that's what we say in Kenya. Ponyoka. Okay, so without much further ado, I'll request Dr. Ganda to take the podium and take us through his presentation. Welcome.
Thank you very much. And I'm happy to be the first real presenter in this conference. I'll try to be brief, and if I'm not brief, you can hit my back. So I think they have already introduced me. I come from a county called Kisumu. Kenya is a country which has devolved function of government. We have 47 counties, and I'm in one of those counties called Kisumu. And Kisumu is one of the few counties which took off in terms of prioritizing primary health care because of our governor's manifesto and the politics around. You know, everyone, when you become governor, you must promise people a few things. So he promised revitalization of primary health care, and that's how we ended up being probably ahead of the rest. So today I'll just be talking about how OpenMRS is powering smart PCNs in Kenya. So this is a map of Kisumu, partly. Kisumu is around the lake. That blue part is the lake. And these are the number of facilities which we have, those points over there. We have 203 facilities, and I liked the mission that I found when I went to the department, that the people before me decided that our mission would be to provide. I have several problems, by the way. One of them is diplopia, so I don't know that look up here or down here. Was to provide a responsive, sustainable, technologically driven, evidence-based and client-centered health service. And I think that was the mission that was given to me when I was becoming a minister. And so it actually adds on to whatever we are doing. So we have 203 facilities, and out of these, 65%, which is 132, are using Kenya OpenMRS platform, the Kenya EMR. 13 of them are in the newer version, 13, that is 3.3.x. And out of these, 11 have full facility EMR, what we call facility-wide system. So just move to the next slide. What Kenya is trying to achieve is on the other end. And what a PCN, for those who don't know, PCN means a primary care network. And a primary care network means that there are several facilities which are working together to take care of a certain population. Now, for them to do that, it means that they need to communicate, they need to share information, and they need to talk to each other. And that's how we have ended up trying to adopt what is called the Kenya EMR for this, to power these PCNs. Now, when we do this, we want to do something called a smart PCN. A smart PCN means that you have totally digitized the PCN, and you are leveraging on technology to help you to bring in those communications. So we have several PCNs. We have 7 PCNs, but out of the 7, we decided that a PCN was too big, so we had 7 sub-PCNs, 35 sub-PCNs. And so we decided to start with a few of them, 3 of them, and share lessons before we move this to the other sub-counties. So one of the ones I'm going to talk about is called the RATA sub-PCN, which is now totally digitized and totally running on Kenya EMR. Next slide, please. So this is the map of one of our sub-counties. A county has several sub-counties. This sub-county is called Seme. And if you look at the area in red, that is a sub-PCN. So if you look at the whole area, that's a PCN, and the middle facility is the hub. That's the main facility. But there are other bigger facilities, which are slightly a bigger health center with more staff, which is what we call the sub-hub, and that is the Rata Health Center. So there are 4 sub-hubs in Seme. Apart from Kombewa, there's Manywanda down here, and Bodi down the other side, and then Rata. So Rata is covering that area. So what did we do? The first thing we did was actually to look at the infrastructure that was required. We were very lucky because part of the facilities were running on Kenya EMR for the HIV services. And so we decided we were going to extend this into the whole ward and all the facilities in the ward. Down at the bottom, we have an electronic community health information system where we have community health workers who are already digitized, and Kisumu was amongst the first to do that. And so we are linking the community health information system to Kenya EMR, which is running all the facilities with one hub. So we went for the infrastructure first, ensured that we bought the tablets, made sure that we had internet connectivity in some of those facilities. We're actually piloting 2 types of internet connectivity in that place, but that is not the topic for today. Then we trained 7 TOTs to be able to train others, because we realized once we do this, then we'll need to spread this information to the other sub-counties or to the other wards. These are the people who now trained the facility managers and the people in the facility. And finally, we had partnerships and collaboration. Without the partnerships, we would never have made it. Without the partners, and I think I'll mention them at the end, they were able to help us with the technical capacity to be able to run this system. Next slide, please. So once we set up this system, what you need is something called a dashboard, an executive dashboard. And we've not developed all of them because we wanted to develop something that is unique for Kisumu dealing with our problems. But we started first with the facility dashboards, executive dashboard. And this was a facility called Railways. I think one of my colleagues is here. She will be having some time to talk later. Victoria. Victoria is here? You could wave? Yes, that is the first facility to have a full Kenya EMR in Kisumu. From these lessons is where we moved it now to a whole sub-PCN. So the dashboard tells you several things. I'm not going to talk about this, which facilities are running, how many patients have been seen, and all that, and I think that's a subject for some other time. Next slide. I want to give my acknowledgements to all these people you see here. You can see their logos. I will not talk about them, but you can see they have something similar within all of them. If you're in this room, probably you'll see the similarities. Most of them are in the HIV space, and so they will draw a lot of lessons from them to be able to power this CCN. I'll be sharing a little bit more when I've seated and when we start talking to each other. Thank you very much.
Thank you very much. And the theme this week is about powering innovation, open innovation to drive UHC. So we've had the journey that Kisumu County has taken. In Kenya, health is a devolved function. So what happens at the sub-national level is very important. And for counties to take on technology and drive innovation at that level is a wonderful opportunity to learn, but also see a grassroots-driven type of innovation. So I'll request Mr. Kamati to give an overview of your journey, just from where you are. Give an overview of your journey in rolling out technology, OpenMRS, challenges, opportunities, how the journey has been. Over to you.
Yes, thank you very much. And good afternoon once again. Thank you, and permit me please to give you the overview of our rollout for one of our OpenMRS-based systems. We call it P-Tracker. It's been 5 years, plus or minus, and this is what happened. One of our success stories, building and rolling out to the system, is that we have successfully rolled the system out countrywide. It is being used in every facility in the country, which is about 343. Right, so all the facilities in the country are using the system. The system now is limited to only one program. It is limited to PMTCT. This is the prevention of mother-to-child transmission of HIV, hepatitis B, and syphilis, although we have somewhat focused on HIV more than anything else. So being limited to just one program means it is not a fully functional EMR system, but we are working towards developing a fully functional system that covers every area of healthcare in the country. So because of our work, one of the success stories that we have recently, as last year, obtained an award from WHO, which is, we got a bronze medal for the prevention of HIV from mother to child. We have also received a silver medal for the prevention of hepatitis B. Unfortunately for syphilis, we could not produce enough data for us to get a medal, but we take what you can get, right? So the 2 awards that we've gotten, we received with open arms. So it speaks to the success and of the work that we're doing. And because of that, we thank OpenMRS and Kenya in general for the introduction of this wonderful system. For those that have been to Namibia, it is a very, very big country with only about 3 million people, right? So everyone is far away, right? So unfortunately, infrastructure is not very good either when it comes to the internet. So we find ourselves using some platforms such as ODK, Open Development Kit, for offline usage, right? So we find some facilities in the far regions, north or east, Zambezi, for instance, internet connectivity is just not very good. So we use offline tools now to enter data that synchronizes every day to the main server that we have in the city. So one of the benefits that we have been able to accomplish using the system, OpenMRS is quite interoperable, right? So we are able to create wonderful dashboards from the data that we collect. We are able to use this information to inform some decisions. As I said, it's limited to one program and one program only, but we are hoping that in the next year or two, we expand that. Actually, work has already begun on rolling it out to every other area of health. We are, however, not using right now, the work that we're doing is not in OpenMRS. We are using the digital health platform that is from WHO. So one of the reasons that we're here is to benchmark and see what works better, what doesn't. Maybe after this, we'll be convinced to switch completely to OpenMRS. We don't know yet. Fingers crossed. What works for us works for us. Yeah. So some of the challenges that we've had. I should actually mention that the development of the system was led by UCSF, by global programs. I understand they have an office here. They have one office in Namibia as well, and a huge thanks to them for their support in building this system. We hope that we can count on their support going forward as well, if we are to choose to implement OpenMRS everywhere else. One of the challenges that we have had as well is the offline capability works well, but not very well. There are issues having tablets in the facilities, out there in the wild. Here, sometimes you can't charge your tablet because power is gone for a couple of hours. So data comes quite late, right? And we have a national data warehouse that is supposed to automatically update all of the data that comes from the facilities. But again, that data sometimes is a few hours late than we'd like, but we get it at least once a day. So that's been very good. So I think on the roadmap to now using the systems or building these systems to make sure that they help with UHC in our country is to make sure that they cover everything that we are doing in the Ministry of Health. They cover all of the programs, not just HIV and hepatitis. And although we have gotten some medals for good work, I feel as if we are 1% done. There is a lot of work that still needs to get done, and the potential for us to do wonderful work with the system is unsurmountable. And I think with that, thank you very much.
Thank you. Let's appreciate him. So we'll be open to share your experiences and lessons learned, because that's what the community is all about. So I'll now welcome Dr. Linafe to share about the story from Malawi.
Thank you very much. I think I'll start off where you have left about benchmarking. It's probably the reason why I mentioned that I've been to Kenya several times, because I think I came on other issues, but twice. First was to MOH to learn about the facilities, digitalization in the facilities. And the second time was to learn about now digitalization. In Kisumu, we had now the field work, I don't know what you call them. Those ones that in our country we call them health surveillance assistants, those community health workers. Yes, because we were coming also to learn about digitalization in the community. This means that for Malawi, we have always wanted to digitize. The private facilities, they are digitized, but not public. So the question was, okay, we need to digitize. Where do we start from? Do we start from the top going down? Or do we start from down going to the top? And that's why we came on those two journeys. And right now, I think we're doing both. There have been some work already in the community, and the partners that are doing the community work are the ones that brought me to Kenya to see. And I think Kisumu County is doing really well. That's why we went there. When I saw him today, I was just, where did I see him from? Then I told him, I remember you, because they welcomed us and we had a dinner, we danced, and nice food, and then we went to Doma Bay and all these things, and then we saw what is happening in the facility. And then we also started in one of the tertiary facilities. That's so in Malawi we've got like 3 levels. We've got the primary, the secondary, that's the district now, and then the tertiary facility, that's a referral facility. And one of the biggest referral facilities showed interest to say we want to be the first to digitize. So we thought, anyway, I think starting something, it's better to start where people have shown interest. So we decided to start there. It hasn't been easy. And that's the reason that we came. And we came, we took a lot of lessons. We came with Paul and Tim, and Steve Wanye took us around in some of the facilities and what Kenya AMR is able to do. I think what Kenya is doing is close to, we could relate to what Malawi wants to do, but I think you guys are advanced. Probably you started a couple of years, not even a couple, years earlier than us. But the dream is the same. So we have a lot of resources coming in the country, digitizing the country, but in HIV. So HIV, I think CDC is the main partner through the implementing partner, EGPAF, who are here. They have done a lot of work in EMR, HIV. I think they are there in all districts in Malawi. So we sat down and said, hey, they're already there, but they're just looking at HIV. Maybe we don't have special money to say, okay, we want to look at a patient in a hall. Why don't we utilize the same, the HIV AMR, and just add modules to make it now patient care centered, like holistically? Because it does not make sense for me as a medical doctor to say, oh, okay, I've checked your viral load, you're stable, but I can't check your hypertension. Go and register, and then you come to me again. It just did not make sense. And I think everybody in my country realizes that digital is the way to go. Starting from the top, it comes from the president, from the minister, and even from my boss that said, okay, let's do this. But of course, the approach was different. I would meet someone who says, no, start from the community. And someone said, no, start from the facility. So that's why I'm saying, okay, we've got some work in the community. We've also got some work in the facility. The most recent one now is the facility. When we left Kenya, I think we came here somewhere in February. We said we're going back to Malawi now. Okay, we're motivated. Okay, let's roll out this and everything. But we have met challenges. The first challenge I would say is attitude challenges, but it's not the way that you're thinking. I think you're thinking negative. I have an opposite problem. I have over-enthusiastic doctors that sits there and then tell me I want a system that will be able to take photos, that will be able to, because I'm in plastic surgery, I should be able to see before and after. Someone is saying, no, I want, so you've got, these consultants. It's complicated because it's a tertiary facility. So you have these consultants that, they've got these very ambitious things that they want this system to do. So the first problem is probably managing expectations, because I think we had been talking about that. And the problem that I noted was my team was just saying yes to everything. I mean, I can't say no, I don't know what they're talking about. I'm not technical. So then I would ask, is this possible? Yes, okay, we'll do it. And then someone would say, I want this, is this possible? Okay, yes, we'll do it. But that backfired. And I think it resonated with a lesson Steve wanted to share with us. Because I would sit with my boss and he would say, you know what? I think he started with a minister. I want a referral system that when a patient is moving from the north, and then he works in a facility in the south, we should be able to trace him and whatever. So we have all these expectations that we want this system to do. But I realized later on that also, because I could relate, I'm also one of them. I'm a medical doctor. I always just think that you IT geeks will just sit on a computer and click, it works. And then we have a system, and I think that's what everybody thinks. But it's been a lot of education to where I am now. I remember when we were talking of this referral thing, Jennifer, who's a colleague of Paul, sat me down and said, do you know what it takes to have a referral system? Hey, you have to have this in place, this in place, this in place, unique ID, blah, blah, blah. I'm like, oh, really? I thought it was just, and then everybody will be seen anyway. And then after I learned that, I sat down and said, guys, it looks like fancy issues when we don't even have a basic, digital system. I think for now, let's just have a system that a person can go in a facility, register, and their record will be there. And the next time they come, it remembers them and say, oh, Nafe was here and she had malaria. I think for now we're good. But if we start to say, I had to learn even through, I also made efforts to study myself because I wanted to educate myself. I know I'm not really there. So, you have to have basic things, infrastructure, connectivity, whatever. It's like a pyramid. And it looks like the peripheral thing that we want is on top when you also don't have this, infrastructure, and all this equipment and everything. So that's a problem to my doctors, who are my friends, my colleagues, by the way. And because I promised them that I'll give you, then 6 months later, they'll be like, where are we? But when I ask my guys, they'll be like, no, for this to happen, this has to happen, this has to happen. And I think this is when now we're realizing, I think we were over-ambitious. We need to remove the fancy stuff and have something that is working. And have an open relationship where if I'm saying something that is unrealistic, someone should walk up to me and say, what you're doing is not realistic. It's not going to happen. Other than to just say, yes, we're going to promise. Because everybody gets excited with these things. But also, we still have the non-believers. I think these days, our generation is better. We have a lot of young people. So these gadgets and everything, but we still have the oldies in the system that have got their own way of doing things that do not want to change. Some even benefit from the chaos. Because where is this chaos, someone is benefiting, drugs are being privileged and everything because you can't find papers, you can't find files for, to go to court for cases when someone sues you and everything. So it suits some people to have this chaos because you can easily tear the file or you can hide it. So I have both problems, yes, where some are over-ambitious and some are, let's see what they're going to do, they're unbelievers. So my job is to be in the middle and give, relatively hope that it's going to happen, but not overpromise, but be realistic, but also encourage this one that no, really, this is really possible. So I think places like Kenya and what helped us. Right now, we did roll out in the central hospital, the outpatient department. Now we were discussing how to, scale up and accelerate to the rest of the hospital and see the lessons that we learned from there. And then, so for now, I think when it comes to facilities, we have done, so Queen Elizabeth, here, about 5 facilities, kind of like learning, where we see, okay, what could go wrong, and then we try and, modify before we take it full scale. But these things are expensive. That's also another thing that I also needed to be educated on. One, managing the experience in terms of time. We're not going to have a system in 6 months, or maybe by the time the whole Malawi rolls up and everything, so maybe it'll be 5 years, 10 years from now, who knows? But the challenges, probably, I have attended several meetings. So I think Africans, we have pretty same problems. Like, separate, programs running in cells, this one, even the same malaria, there will be net distribution. Then there will be this one it is about now drug treatment and whatever, and it has its own system as well. So trying to leverage that to bring everybody together. I'm kind of like the person in the middle that understands when these ones are frustrated that I'm taking long, but I also understand that these guys are doing the best they can, and this is what they can deliver at the same time. The same issues, I think the other issues are the same. The same infrastructure issues. Maybe Kenya, you are better, because I saw that. We are not yet there. But the same gadget issues, connectivity. We are at least we have managed about the bills, about the connectivity. We found a cheaper way. But, for sustainable these things, we have to, make sure that all those things are sorted for us to be, increasing gradually and to get to where we are. So thank you once again, Kenya, for all the lessons that I learned here. I hope one day you'll be able to come to my country and I'll stand where you are and busy showing off and say, we have done this. That's our facility, but I have learned that, this thing takes time. And we have to do these things, we have to do them proper, and we have to do them really well. And probably we have to show that we know what we're doing, to have donor support, the CDCs, to tell EGBAF to say, okay, work with DHD to make sure we scale up with this. Now, I don't know if we call it MAHIS. Your Kenya EMR, us is Malawi Health Information System, so it's MAHIS. So let's hope next time you come to Malawi for the OpenMRS, I'll be there. Like my Kisumu minister saying about Malawi Mahis and how many facilities we have rolled on and all these things. Thank you for your attention.
Thank you very much. Let's appreciate Dr. Alina Afe. So you'll recall that she said that she visited Malawi, and what she remembers is they were taken out for dinner, they danced a lot. Sorry, to Kisumu. And they danced a lot. That's Kenyan hospitality. If a Kenyan doesn't take you out and you dance, something is not right, yeah? The other, nyama choma. The other takeout is that there are challenges when it comes to scaling out digital health innovations, whether you're scaling out at the community level all the way up to tertiary. And for that, I'll ask Dr. Kimanga to share the story. Having been on the government side, having been on the donor side, having been in the HIV space for a long time, how have you seen that journey? Do you identify with the challenges that have been shared? And are we there yet? Over to you, Dr. Kimanga.
Thank you, Pascal. Maybe what I wanted to start by saying is that Kenyan hospitality includes a dance in the evenings, but for this conference, we brought the dance here. Yeah, and I saw Hakuna Matata really being danced to very, very well. So for me, and thank you for this opportunity, I I was in the ministry when all this started, way back in, I think I joined the National HIV program in 2009, and working very closely with Dr. Jacob Odhiambo, who is now the project director for this project, and Dr. Lily, she's seated somewhere, I think she's doing an assignment, who is now the SI program manager at the National HIV program. And we realized very, very early that it is going to become increasingly difficult to manage the HIV patients using paper-based records. Any chronic care, if you look at it critically, you realize that a client who has been on treatment for like 20 years would need a very huge file that will have problems maintaining. We had also come up with it's called an ART register, and whatever, what does ART even stand for? Antiretroviral therapy register. Nowadays we are digital on everything. And we realized that when you first design it, it's supposed to take like 4 years. Then after 4 years, so how do you handle? Do you go back and start from the 5th year, or do you go back to year 1? So with all that, we actually made a decision that this was not going to work alongside the USG in Kenya. And I remember, and thank you, Tom Oloch is standing behind there. I remember us having a discussion and really thinking through how do we resolve this. And the USG came in very handy to agree with us that we can definitely roll out electronic medical records initially for the HIV program, but our understanding was that if you have it for the HIV program, then you'll take care of any chronic disease that you are looking at. And even then, far back, we still had the vision of saying at some point, this will really cover the entire facility. And I'm happy to really share updates on where we are. So how did we get here? Number one, we were coming up with this when there were already many systems being implemented. I did not want to kill innovation. So our first step was to say, can we develop EMR standards and guidelines? And all we were aiming for is to get to a point where all systems will be allowed to operate so long as they were meeting the standards. So that was the first thing that we did in 2010. The next thing we then did is we went out to assess the existing EMRs to see whether they were meeting the standards. And when we did that assessment, guess what? What system came top? It had to be OpenMRS, obviously. Yeah? So OpenMRS became number 1 in that assessment. Number 2 was another system called IQ Care. I'll tell you its story. And then number 3 was another system called CPAD, supported through ICAP. And the last one was a FundSoft. FundSoft is a system that is used for financial management within the facilities. These were systems that were widely deployed within the facilities and were in use then. So that's how we got to selecting OpenMRS as our core system. Then we went ahead. The OpenMRS that we chose is the one that was being used by AMPATH, and that is, Paul is here, so he knows more about that. So that's the one that we assessed. But now when it came to the actual rollout, one of the things we realized is that it was being rolled out in a centralized model, and what we wanted was a system that will be deployed at a facility as a standalone, because we knew that it was next to impossible to connect all facilities. That was way back in 2010, before we came up with the cloud EMR implementation. So we tasked the partner who was working on Kenya EMR then to actually build a standalone platform that will then be deployed at every facility. And that was the birth of Kenya EMR. Fast forward to 2017, Tom had left CDC, and he encouraged me to apply for the job at CDC. So I got his job, and I'm glad you went away, Tom. Thanks for creating a vacancy. And when we came back, then we found ourselves in a situation where we had 2 systems that we were supporting, the IQ Care and Kenya EMR, and both, there was one partner actually doing both. And every time they were making a change, they had to maintain 2 development teams. So you make a change here, then you have to go to the other side. The other thing that happened within that arrangement is that there was even internal competition among this, which sometimes is good, but it can also turn out not to be that good. then it wasn't efficient from our end, because I remember at some point we made a presentation to our donors and they were asking, you mean you are maintaining two systems using the same resources, and every time you are making changes you have to go to both? It didn't make sense. And MOH, again, also did not like the fact that we were supporting multiple systems at that point using the same resources. So we had a discussion and we agreed that we needed to choose the most sustainable of the two and then do a migration. And that's when my friend Pascal came in. So one, we got the matching order from both the MOH and our donors. And then two, Pascal came in and that was his first task, to prove himself. And the requirement was that we needed to migrate 700 facilities that were using IQ Care to Kenya EMR that was then deployed in 300 facilities, and that needed to occur within a year. The man standing here, by the way, let's clap for him. He took up that challenge, and I can assure you, and I know a number of countries are struggling on migration. That migration was completed within a year. Then we moved to one system, that's Kenya EMR. So as you come here today to see the work that has happened, and I'm really looking forward to your site visits on Thursday, and even those other many discussions that we've had, it really demonstrates how far we've come to where we are. So the next thing that I wanted to say, come 2023, that's towards the end of last year, we received matching orders from the ministry. And again, I must acknowledge the great leadership that the ministry has provided. And they told us that they are a ministry of health. They don't only focus on one disease program. So if HIV, the EMR was going to remain in that corner within a facility, and you had Dr. Manya alluding to that corner discussion, then it was going to become obsolete. And that was clear guidance. So of course, we went into some bit of panic, but we also realized that we are not alone in this space. That's when we tapped into the community, collaborated with everybody to really say, can we build a facility-wide EMR in the shortest time possible? I had my sister here saying the donor requirement and the donor regulation. Fortunately, in the recent past, we've also gotten to a point as an HIV program where our clients are dying from other diseases that are not necessarily HIV. So we've done a very good job of managing HIV, but our clients are dying from NCDs and other diseases that if we don't manage, then we are not attaining the goal that we wanted. So that aspect of saying, can we be patient-centric? And that's actually part of the global COP guidance, that we have to implement patient-centered care. So we got the matching orders, and I must really thank the Palladium team and the collaboration with the community, because within 3 months, you know, I made a promise as a donor that we were going to be ready in February. But I also knew that they had our back. And sure enough, by February, we had a facility-wide system. That now the Kenya EMR that used to be HIV is able to cover all departments within the facility, including things to do with billing, lab, commodity, and everything else. How did we get there in 3 months? The collaboration at the community level. We didn't have to reinvent the wheel. We went out there and asked, do you have this? Can we get yours and customize? And as we do that, we'll also give you this, so that at the end of it all, you have this solution at this global level. And I think that's a big plus, because as we sit here as a community today, we all are collaborating to build a powerful solution that meets our needs. My sister said our needs are similar across board. We're managing infectious diseases and non-infectious diseases and all those other things. One thing I must state is that, one, the US government has been a strong and dependable partner in this entire journey. Primarily, initially, because they were focusing on HIV and TB control, and then the other focus is pandemic preparedness and response, but now they've also become a strong partner in the universal healthcare space. So we do have an opportunity to really support UHC and get to the better healthcare outcomes that we are aiming at. Number two, our success factor is really the great government leadership. I mean, when I was in the HIV program, Dr. Manya was at the HIS division, yeah? He was my boss. So even as you tackle everything HIV, you report to Dr. Manya. And that kind of leadership, that shared vision has remained there consistently from that time to now. So we are where we are because of that great government leadership. I must also not forget the responsive partners that we work with. Palladium has gone through a lot. When we first had Jacob reporting to Palladium, he didn't have white hair. He's grown wiser over the years. Yeah? But we can see the results. And I'm sure as you visit the sites, you'll be able to see all that in action because it's been done. My challenge to all of us who are here is tap into the USG support and other stakeholders. Number 2, collaborate. Let's share everything. Initially, I know Kenya EMR was separate, but now it's part and parcel of the community. So really we are part of the reference application, and that's what we are expecting, so that we all collaborate within that space and keep improving it so that it's far much better than how we found it. And I really must appreciate, Grace, your great collaboration at that level is something that we really don't want to take for granted. So that's how far we've come. There are many lessons, many successes, but what I'm saying is don't take 15 years. You can now get there in 2 or 3 because most of the problems have somehow been fixed, and the ones that are remaining, let's fix them together so that it doesn't take that long. Thank you, Pascal.
Wonderful, 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 wonderful. And may I take this opportunity to also appreciate OpenMRS team, Dr. Paul Biondich and your team. Please rise up. Let's acknowledge the OpenMRS Inc. team, the directors, the leadership team. Let's appreciate them. And let's also appreciate the partner ecosystem, right? You've heard about UCSF, you've heard about EGPAF, Palladium, and you'll hear about METS supporting and working very closely with the ministry to advance its own priorities. So let's appreciate the partner ecosystem. And definitely government leadership. That has been emphasized by Dr. Kimanga. So on that note, we'll hear more from the Uganda story. Dr. Kimanga has mentioned that we are benefiting from the partner ecosystem, right? We are benefiting from the partner ecosystem as we contribute. And many of the advancements being made in the ecosystem are direct. The direct beneficiaries are the ministries, right? So then, like I know in Uganda, there's METS, there's leadership from the ministry. How has the journey been, and what is the way forward in terms of your challenges, addressing your challenges and the opportunities that lie ahead?
Yeah, thank you very much. I must recognize that because of the life course, my memory might not serve me very well. I might forget to remind the Kenyans in the house that we'll be looking forward to this hospitality this evening. I'm not the one who talked about it. So we're looking forward.
Be warned that Ugandan hospitality is on another level.
Yeah, but I think it's important for us to, as we reflect upon efforts towards digitizing health services, that targets around universal health coverage are off track. Initially, we saw some progress. Then we saw reduced progress. Now we are seeing stagnation and even reversals in terms of coverage of some of the health services that we provide. This presents a unique opportunity for those of us who are involved in digitization to demonstrate that there's a value proposition that we can make in terms of changing actual health outcomes when we try to digitize health services. There are two issues here that you could look at. One of them is from a reporting and accountability point of view, and the other one is from really providing job aids to health workers to ensure that the task of providing health services is as painless as possible. In Uganda, of course, we've made significant progress towards ensuring that you have systems that can feed an accountability and reporting machinery that can later on be used for some level of strategic reporting. However, on a day-to-day basis, frontline health workers struggle with decisions that they have to be making at micro levels. Like has been highlighted before, sometimes the best health, the best data protection that we are providing is to ensure that your records are on a heap of paper somewhere. But the truth of the matter is, all human beings are naturally engineered towards making data-driven decisions. However, in the absence of data, they will use anything available to them. In statistics, they say they will impute. That imputation could be a dream you had last night, or some of your relatives helping you prioritize by saying, we went to a health facility and this was our experience. So the real question we should be asking ourselves is that how can we optimize access to data? And this is really when you're talking about from an accountability point of view, but also from a care point of view. At a very micro level. How can you optimize access to data to facilitate and improve how we care for our patients? We've made some progress and we've used Uganda EMR in our HIV clinics for a while, and to a smaller extent we have expanded it to other service areas, but we also have digital tools that we have deployed in other service areas. But we must, first of all, at least in the context of Uganda, while we can talk about the benefit while we can talk about the success we have made in terms of an output, we've delivered the computers, we've put the EMRs, we've come up with reference databases like the facility registry. Okay, some of them are more elusive than the others, like a client registry, so we're still struggling with those. But there are those that are simpler, like a facility or maybe a terminology service that we've been able to put together. However, clinicians are still struggling to use this as a mechanism to optimize access to information that would allow them to improve care. Like has been highlighted before by colleagues from Malawi, one of the benefits we thought we would have by digitizing is optimizing our referral. We have patients accessing care from across platforms, but then we struggle with having appropriate infrastructure. And this has made the benefit a bit elusive for us. Power infrastructure, which might seem completely out of our scope, is a major determinant for our success. Ensuring that you have a reliable local area network. And you know, the problem we've had is that we've had our networks in our health facilities growing spontaneously. From having one computer being managed by a records officer, where you're doing retrospective data entry, patient is managed using paper and then the record is captured later, to you saying, okay, can we add one computer here, and then you run a cable, before you know it, you have a network that was not well thought out. It just grew. And now it starts misbehaving when you have significant numbers of users, you have congestions in the network, people cannot save when they're looking at seeing patients, they cannot retrieve patient records. These are some of the things that are causing for us problems. And there's indeed an opportunity to tap into the community to see how we can solve these problems. Of course, it was hard for us to imagine some of the challenges that we are having without making the strides that we've made. Now that we've made them, if I might borrow from one of the former American politicians, we had what we call unknown unknowns. Now there are things that we now know that we didn't know. So we can tell now that there are these problems that we need to solve, but a few years ago, these problems were not in our worldview. We thought that we'd deploy these tools and would have certain successes. So in terms of using this data in terms of using these tools to ensure that in the domains of compulsory data use, basically you're talking about planning, you're talking about accountability, we have scored very well. But in the domains where people have to exercise their own judgment, to, for example, reach the dashboard that was shown here, you need to do your own judgment that now I need to go and see the dashboard. There's nothing compelling you. We've scored very badly. And for us, these are some of the places where we need to put in some work. How can we optimize the process of accessing all this information that we are generating? Some of the things that we can learn from social media is passive data collection. But also, when you use social media, many times they don't tell you that, oh, you went here so many times, you went there so many times. They just use that data to optimize your experience. Now the question is, while we see patients, while we use the tools that we use, while we collect data, there is an opportunity for us to use this data to optimize the experience of the clinicians and by extension, the patients that we manage. Now, what we've used this data for, at least in the case of Uganda, in terms of optimizing the experience of a clinician, in terms of optimizing the experience of a patient, has eluded us as yet. And if the community can help us solve some of these problems, indeed we acknowledge the success that we have made in easing the burden of ensuring that is data available for reporting, for accountability, and for planning. But for us, we consider these compulsory domains of data use. And we would like to facilitate clinicians at the time when they should be using their own judgment. No one is twisting them to retrieve the data. Can that aspect be simplified as well? So we've made progress in terms of having these tools. We are having challenges with supporting infrastructure. Attitude is a bit of a challenge, but those we are figuring out how to deal with them. I think we had a misunderstanding in terms of the meaning of what do you call it, change management. In all our change management sessions, we were teaching people what change management was. We were not helping them to transition, actually. So we were not reaping the associated benefits. But the main core thing that we could do is, first of all, ensure that we have supporting infrastructure, but be more creative about how these tools can actually benefit the clinician in terms of having a better experience. All of us are lazy people. Okay, at least I am. Anything that simplifies my work should be welcome. Thank you very much.
Thank you very much, Mr. Paul Mbaka. We'll shortly open for questions. MC, if there are any questions already posted online. But as we think about the questions we want to pose to the panel, I want to pose a question to the Kisumu CEC. And here he talked about the fact that there is a smart primary care network whereby you have hub and spoke connecting a number of facilities to the community and so on and so forth. So my question to you is, how have you been able to sort out the infrastructure challenge, which is a common theme that has come up? And what are the innovative ideas to address questions around infrastructure gap?
Yes, thank you very much for that question. It's a difficult yet easy question because I can talk about that for an hour. but I'll try and summarize and just talk briefly about the problems that we had. My colleague talked about where do you start from. Kisumu decided to start digitizing from the community. And that was it was a huge hurdle because that's a lot of money that is required. And that for us was a political decision because once we decided that we want to do this, we had to get the top person in the county, the governor, to accept, because then you had to convince the MCAs that when this is put in the budget, you'll have to accept. And that is a huge, almost 25% of the current budget. So at least by the time we are finishing our year one, we did this in 1 year. I think no county did this using their own resources. And of course, with the help of our partners who are the digital tools, we were able to do the community system. But then came the next thing is that that infrastructure includes where you save that data. And initially, it was extremely difficult to get data for anything. As my colleague has spoken now, he really spoke to me because when you want to solve problems at the micro level, for example, you want to recruit people into health insurance, you need to know them by name. But then the authorizations from the Ministry of Health were that we cannot give you de-identified data because then we are the only ones allowed to have that. And so that became a problem. And so we had to think that, okay, fine, we need to have a warehouse where we keep things. So we had a warehouse in Kisumu, which we used temporarily, but learning from some of these conferences, I think from Elizabeth Foundation or something, we learned that it was actually cheaper to do it on cloud. So we changed and we bought some cloud space for Kisumu. But coming to the facilities, many of our facilities don't have internet, they don't have hardware, they don't have desktops. But again, we learned from some of our partners that the use of tablets was a very good idea. So we visited the facilities which were using tablets. We found that it was something that is workable. And the beauty about them is that they can put a SIM card inside and then you type in and then you're connected to the internet. But that doesn't solve it because some of the facilities don't even have that internet you're talking about. So that means that you need a place where you can type in the information. But when you carry your tablet home and it finds internet, it connects and it saves the information. So that's how we were able to counter the battle of internet. Some of those places don't even have electricity, meaning then that you have to give a policy that you can actually carry your tablet home, charge it, then come back to the facility. The next thing is how do these facilities connect inside this network? It meant that then you must have a system that is able to save information, upload, but also connect to the other facility in one go or in different goes in different times. So it needed something that is, what I say, malleable. That's how we went for Kenya EMR because we visited all these places, all these systems. We went to Kenya, I sent a team, they went and learned, and then they said, this is not going to work, and said, how do we deal with these things? So there are still a few challenges that we have because of electricity and connectivity, yes, but we are hurdling through those with the innovations that we have. There's another innovation which I don't want to talk about, which has internet and electricity, but it's still on a pilot basis, that causes you to have intranet, but it's not internet. So basically, once you have electricity, you don't need internet, it will be intranet, but when there's a little power or a little, what do you call it, network, then it uploads. It's called Signalytic. I'm told it's being used in Uganda. We are piloting it and seeing if it will help us in some of our facilities because it also has the solar system that powers the facility in terms of energy, but also gives you connectivity. Thank you. I hope I've answered.
Yes, thank you very much. Is Brian in the room? Signalytic. You can talk to Brian from Signalytic. It's a very good innovation. We've worked with you to customize it here. So if you're thinking about low resource settings, wonderful. Any questions for the panel? So I'll ask, so there's a question on the scale of facility-wide. There's a question on data privacy, especially for the tablets, and availability of options. So I'll ask Dr. Ganda to speak to the question on data privacy, especially when tablets are being used to collect data.
Thank you. I think that's a very good question, and we had a lot of thinking before making some of these things or making some of those rules. What we've learned is that this is Kenya, this is Africa. Some of those tablets get stolen even in those facilities. So even if you keep it in the facility, they can break and steal those tablets. And actually, they are more secure in terms of theft inside your house than in the facility. But that not be, you assume that these health workers are responsible people and that these systems have passwords, that you cannot walk into a system and just open in and steal data. You will have to enter in with your password before you access information. And so it means if somebody is accessing, then it means that you actually gave them the password. So you have to choose between having the system work or not having it work. If you look at internet connectivity in some of our countries, I think things are going to get better. We have, like Kisumu has 69% places with internet, which means 30% of the places do not have internet. We have facilities which have to bill the patient by carrying a laptop to the gate so that you access your NHIF internet. So it is not as easy as somebody might think. I think that was the only question that I had. Thank you.
Thank you very much. Dr. Kimanga, you can address the question on the scale currently on facility-wide and the question around availability of options. How do you deal with that? And probably anyone else can respond to that. Yes.
Thank you. Thank you. So facility-wide, we just started a few months back. And right now we have 100 facilities that have been upgraded to the OpenMRS 3.0. And then out of that, 60 are facility-wide. So that's where we are. But remember, this just started. Good news is that with the great government buy-in, the digitization that we are having, and the upcoming rollout of the social health insurance, it's going to be a requirement moving forward that digitization is the way to go. So you need to submit your bill digitally, but it's not just a bill, it's a bill together with your shared health record. So the expectation is that we will keep expanding, and I believe by the end of the year, we should be at a very good place in terms of facility-wide implementation. I like the question on options. I think to me that's a very good one. And I'm saying this because the way we approached it, let me explain how we approached it. Number one was to make the system good enough for the user. Initially, our systems were for data. You remember PEFA and the amount of data that they need and all those things. So that's how the systems were built. But over time, we were able to move away from that and build systems that were tailored to the processes, the clinical processes. When they were data, mostly what happened, we needed to employ data clerks. So at the end of it all, you will see the client capture the data on paper, and then thereafter have a data clerk enter data into the system. At some point, I remember Tom is here, we built clinical decision support, but who was seeing the clinical decision support? The data clerks. So that was not helping because the patient was already gone. So we focused on making the system work for all the healthcare providers at the facility level. So that was point number one. The moment we got that right, then we said the next thing is we don't need paper within those facilities. Fortunately, we didn't have enough resources to continue printing the registers and the encounter forms. So I remember at some point, PEFA actually said we don't have money to print. The money you're using to print, go ahead and buy tablets for deployment at the facility. So that particular option of paper versus EMR actually went because no more registers, no more papers at the facility level. And that also meant that even during supervision, you know, people never really believed that a soft copy of a register is good enough. So they'll go to a facility and say, I want to see a hard copy because that hard copy is the true register. The soft copy doesn't work. But what we did is that we built all the registers within the system. And right now, as you go to see Kenya EMR on Thursday, you will see all those. The reports are inbuilt, the registers are inbuilt. They are very nice line lists that really help the clinicians to go through the process, whether you are an adherence counselor, you are an HTS counselor, you are a clinician, you are a pharmacist, that workflow speaks to you, and at the end of it all, it makes your work easy. So that was important. Collection of data is happening at the back end without them necessarily knowing. So first, make the system good. Second, eliminate the options. And once you eliminate the options, you won't have a problem altogether. The digitization agenda by the government will help us because if the billing has to have the bill and the shared health record captured digitally, then we don't have an option. We have to get to where we need to be. Was there?
Yeah, Paul, over to you. I think,
Okay.
yeah, thank you.
Yeah, thank you very much. Maybe I can start by poaching a bit on the question of device management. In Uganda, we've also had this challenge, and we are using some device management systems to try and restrict what the devices could be used for. But I would like to associate with all the challenges that colleagues are facing. It is quite similar across on the other side. As far as ensuring that we do the transition from EMRs, of course, we must appreciate how the systems were introduced in our health sector. Originally, they were mainly partner-driven. So that kind of laxity of this is optional has always been there. In Uganda, we have changed the approach a bit. And for facilities where we believe that sometimes you can enforce when you have not made reasonable investments. But for facilities where we believe we have made reasonable investments, you have fairly good infrastructure. The Ministry of Health has issued formal circulars instructing the facility to completely transition away from paper. We've also come up with what we are calling a downtime strategy or downtime guideline or downtime SOPs. If for some reason there's no electricity, there's no blah, 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 there are specific procedures you're supposed to use to ensure that you can manage the patient and then dovetail the data back into the system. Thank you.
Thank you very much. Let's appreciate the panel. Wonderful job. In my reflection, I'd say that countries are at different stages of embracing digital transformation. There are countries that are at the point of digitization, that is taking manual and converting to a digital equivalent of a register. There are countries that are going through digitalization, in this case, looking at workflows built into the system to support clinical workflows and so on and so forth. And there are countries that are looking forward to digital transformation, where there are new business models that are embedded within the digital transformation journey. And for each level of country, there is a challenge. Challenges are always there, right? What it takes is leadership and working together as a community to take things forward. There will always be challenges, at whichever level you are in your digital transformation journey, in your digitalization journey, or in your digitization journey. So I just want to encourage us that as a community, let's take on these challenges. Let's take on the opportunity with equal zest and zeal, and let's build on what we are doing together to build the community better. So thank you very much. I have been your moderator, Pascal. I'll request the panelists to stand here for a photo op, and then I'll hand over to Laban Cliff. Thank you.